Dr. Johannes Hebebrand, who's from the University of Duisburg-Essen in Germany. So Dr. Hebebrand studied medicine at the University of Heidelberg and received his PhD from the University of Bonn. In 1995, he became head of the Clinical Research Group for Genetic Mechanisms of Body Weight Regulation in the Department of Child and Adolescent Psychiatry at the University of Marburg. He holds his current position as head of the Department of Child and Adolescent Psychiatry at the University of Duisburg-Essen since 2004, and is a board member of the European Society for Child and Adolescent Psychiatry. Dr. Hebebrand has been working on both sides of the energy balance equation for many years, studying both starvation, low body weight, and on the other end of the spectrum, obesity. His research is both of a fundamental and clinical nature, having made significant discoveries studying both the human condition and rodent models. His group has been involved in several international consortia to detect polygenes for obesity, anorexia nervosa, and attention deficit hyperactivity disorder. And relevant to his talk today, Dr. Hebebrand's group has figured prominently in uncovering the clinical implications of hypoleptinemia in patients with anorexia nervosa. So this work has culminated in some very exciting findings that he will share with us today. So Johannes, thank you so much for accepting our invitation and for taking the time to speak with us, especially on this Friday evening, your time. The floor is yours.
Stephanie, thank you very much for the introduction, and bonjour. I hope there are not too many French-speaking people around, but because my talk will be in English. What I want to do today is to go through a lot of material related both to clinical aspects of anorexia nervosa, but also of starvation, and to introduce the concept that leptin is a crucial hormone for the adaptation to starvation, and via this function is also important or may be of potential benefit in the treatment of patients with anorexia nervosa, even if that may sound paradoxical to you. So first slide just shows my conflicts of interest. Just to point out that Christina Barth's foundation funded some of the Metroliptin case studies that I will be talking about later on. So first aspect is, how does leptin reach and enter the brain, where there are leptin receptors localized throughout the brain, for instance, prominently in the cerebellum, but also in many other regions, obviously also including the hypothalamus. And leptin is taken up via the median eminence, but also via the choroid plexus, and particularly via the choroid plexus. It reaches basically all brain regions. Via the median eminence, it enters the hypothalamus. After 45 minutes, basically leptin can be, after application, can be found throughout the brain. Now, all of us, or most of us, are probably familiar with these pictures. The mice shown on the scale here were published along with the original study on the cloning of the leptin gene back in 1994 by Jeff Friedman and his group. And later on, Sada Faruqi used human recombinant leptin to treat patients with congenital leptin deficiency. And as you can see, the effects are quite obvious. And these obviously have led to the idea that leptin is an anorexigenic hormone, and that is involved in appetite and body weight regulation. Now, the prevailing view is that leptin mediates resistance to obesity by its levels rising in response to an increased energy intake. And indeed, if you apply recombinant human leptin to wild-type mice or to lean humans, indeed, you've come up with weight loss, even though this weight loss takes time to develop. It's not an instant, or people do not stop eating, but rather it's a rather slow process in that that at least some of them start to lose weight. However, and this is important, there are only small effects upon treatment of obese wild-type mice or of humans with obesity. There were studies, RCTs, related to the use of Metroliptin in obesity, and none of these studies really came up with a significant effect of Metroliptin in contrast to placebo. So Flyer, Maratus, and Flyer argue that this unusual dose-response relationship entailing effectiveness in low to normal weight and resistance in subjects with obesity is uncharacteristic of any known hormonal system. So they argue that there must be another function relevant that applies to leptin. And indeed, in 1996, Ahima and colleagues came up with this alternative hypothesis that leptin signal is crucial for the adaptation to semi-starvation. And they showed that the starvation-induced drop in leptin entails changes in the gonadal, adrenal, and thyroid axis. And so they postulated that leptin is involved in the regulation of the neuroendocrine system during starvation, and stated that this neuroendocrine adaptation via the hypothalamus, pituitary, end organ axis is the major physiological role of leptin. Now, what I'm trying to hint at, or our hypothesis is that maybe we can think of going beyond this neuroendocrine adaptation to state that leptin is the major signal for adaptation to starvation, because leptin receptors are obviously not only located in the hypothalamus, allowing for this neuroendocrine adaptation, but they're also located in many peripheral tissues and in many brain regions. So the effects, and this has all been shown, there are effects on reproduction, liver and enteric metabolism, hematopoiesis. There are psychological and behavioral effects. Maybe leptin is crucial for the upcoming, or the induction of these both somatic and psychological phenotypes with respect to starvation. So if leptin levels fall below a crucial level, then the graded response to starvation sets off not only the neuroendocrine adaptation, but maybe also in peripheral and tissues, but also obviously in the brain. So if this is true, then we definitely need to know, at least as a psychiatrist, or if you're interested in the central function of the central nervous system, as a potentially also psychologist, neuroscientist, then we need to know what are the effects of starvation in humans. And there's been basically one experiment conducted back in 1944, 1945, published by Ansel Keys back in 1950. In 2 volumes, book is titled The Biology of Human Starvation. They had 36 conscientious objectors who volunteered to participate in a 12-week baseline program, then 24 weeks of starvation to induce weight loss of 25%, and then 25 weeks of weight rehabilitation. These probants had to walk 22 miles per week. They had defined duties. And obviously this team had a very sophisticated assessments for that time to look into somatic and psychological changes during this starvation. And what did they find with respect to hunger, appetite, eating behavior? These, many of you may know of these findings. So there's preoccupation with thoughts of food. They are hungry all the time. They talk about food basically at every conversation. They have daydreams of food. Interestingly, many wanted to become a cook after a completion of the experiment. At least that is what they thought during the starvation time. They or rather soon abandoned individual food dislikes. Their eating behavior changed. They started to eat alone. They ate a lot of, or consumed a lot of fluids. They used more spices and salt, and they actually added water to the food to stretch it, and this was termed souping by these probants. There are other adaptations, psychological adaptations. So a major issue was tiredness and exhaustion. The mood became depressed. There was rigidity. They reported very substantially reduced sociability. Libido crucially went down. It's nice to read this in the book because these men, some gave in early, other gave in later, and they had lots of discussion about this. Spontaneity and creativity decreased. The concentration and short-term memory also were worse were perceived as getting worse on a subjective basis, not as much on an objective basis. And then there was reduced physical activity, but nevertheless, these males reported being restless and nervous. This is just a figure out of the book. And as with many other species, there is an increase, as you can see, with the preoccupation with food over time. So this is starvation, this is baseline, week 4, starvation 8, 12, so on. And this is the R6, R12 are the 2 weeks, week 6 and week 12 during realimentation. So the preoccupation with food goes up, and at the same time, activity goes down, and also the interest in sex also declines. This can be found for many animals. However, if you look across species, then there are substantial differences. For instance, eels will reproduce upon starvation. So this is what common to many vertebrates, but not to all. And you may even have opposite effects, for instance, with respect to reproduction upon starvation. So if we now look at, if leptin is involved in these in this adaptation, then obviously we need to assess the phenotype of, for instance, and this is crucial, patients with congenital leptin deficiency. And in particular, we could start off, as I did with the Minnesota semi-starvation study, we could start off with eating behavior. And here you can obviously see quite a difference. Hyperphagia is the term most commonly used by the by investigators who have assessed these patients. There's other terms have been used: continuous demand of food, voracious, insatiable appetite, aggressive food-seeking behavior, which gives you an idea of what these children are up to. The test meals are consumed rapidly. They, in this case, disliked foods were not eaten, and children requested food again shortly after a meal. Now, it turns out that the obesity is not evident at birth, and it develops actually during the first weeks to months of life. And already during infancy, obviously, the parents are, or at least the mothers are quite busy because they have to feed every 30 to 60 minutes until they realize that something is definitely wrong. There are indications that the appetite is no longer as strong in adulthood as in childhood. So if you now attempt to look at the psychological aspects that have been detected, or psychological features that have been detected in these patients, obviously not very many of them on a worldwide basis, but nevertheless, there are quite a few publications by now. And interestingly, mental aspects have been of minimal interest only. So I will show you basically the one study that did suggest that there are substantial changes, but they are not very precise about the changes that they did observe. So these observers, these investigators, Licinio and co-workers, stated that there was no depression or anxiety at baseline, so there's no change, obviously, upon initiation of Metroliptin treatment. The most immediate change, obviously, is the change in ingestive and non-ingestive behavior. Ingestive meaning that the appetite is reduced, they eat significantly less. And for non-ingestive behavior, despite the fact that they had highly, as they write, this is a citation, highly experienced clinical research psychiatrists in their group, they just summed this up. Non-ingestive behavior of all three patients was consistently observed to change from very docile and infantile to assertive and adult-like within weeks of the onset of leptin treatment before weight loss occurred. This was a subjective but universal observation made by the treatment staff, which, as I said, included these trained psychiatrists. But this is not, as a psychiatrist, one would actually prefer this to be somewhat more concise. So I recently had the opportunity, due to Martin Babic in Ulm, who was treating a patient with congenital leptin dystrophy, congenital leptin deficiency from Saudi Arabia. I was able to interview this female with a particular focus on starvation-related aspects. And so the first part of the interview was non-directive, and the second part was then to raise questions on particular starvation-related mental behavioral alterations. So in the first part, this female vividly describes that she was thrilled by the experience of having Metroliptin for the first time in her life, stating that this was magic in the sense of a feeling of liberation. She particularly was fascinated by the very rapid reduction of the preoccupation with food, which up to that time had kept her busy her whole life. And that she was then more, she stated that I saw her the interview was 10 days after she had been put on Metroliptin, and she stated that she thinks that she could now be in a much better position to actually achieve a more healthy lifestyle for herself. So questions related to starvation-related aspects, she reported less awakenings. So people who are starved have sleep disorders and have many awakenings. So she reported a slight reduction in the number of awakenings. She did report a significant mood improvement, which she thought was very tightly linked to the reduced preoccupation with food. She reported being more spontaneous, more focused, having a better self-management and self-organization, which she did not have, or where she didn't think that this was very closely related to the reduction in the preoccupation with food. So this is basically, this is all there is to. There's one study on IQ potential IQ elevation of a boy who received Metroliptin, but there's many questions to this study, so I didn't include it in my slides here. So now, next step, anorexia nervosa, the core phenotype. The psychiatrists among you are obviously well familiar with this. We have basically a sex ratio of 9:1. At least from a superficial layer, the clinical symptomatology seems to be rather homogeneous. The disorder occurs, let's say, between age 10 to 25, no manifestations in children, no manifestations later than age 25. It's characterized by the intertwining of the primary cognitions, I will go into this, and behaviors with the somatic and psychological consequences of starvation. And that this intertwining then represents the core phenotype or the core symptomatology of anorexia nervosa. And as such, there are, and this has been observed for quite a while, is quite a substantial overlap, obviously, with the symptomatology observed in the probants who had participated in the Minnesota semi-starvation experiment. So these are just primary cognitions, which are not characteristic of people who starve for any other reason: fear of gaining weight, fear of becoming fat, persistent behavior that interferes with weight gain, body image disorder, undue influence of body weight or shape on self-evaluation. Obviously, people who do starve recognize the seriousness of the low body weight. In anorexia nervosa, this is not the case. And there seems to be a paradoxical increase in activity levels in a subgroup of these patients. Now, the starvation findings that apply to both the probants in the Minnesota study and in patients with anorexia nervosa are listed here. And basically, I don't need to go into this, but recapitulate the findings that I had just pointed out for the Minnesota study here: social withdrawals, preoccupation with food, just to name depressed mood, just to name a few. Hunger is actually a phenotype, appetite and hunger phenotypes not really very well investigated in patients with anorexia nervosa. My personal impression is that in adolescents, most of them and convincingly tell you that they no longer have appetite, that they no longer experience any hunger whatsoever. There are exceptions to this rule, and I think the adults whom I do not really work with and thus have less experience, that I think a larger percentage of the adult patient population does experience hunger. So we initially, back in 1995, this was 1 year after the cloning of the leptin gene, we had a perfect opportunity to have leptin levels assessed in serum of, I think, of 6 patients. And at that time, at that early stage, we had the hypothesis that maybe leptin levels are elevated in these patients, leading to them not being hungry and not eating. This proved to be totally wrong. And as this later study here in 1997 shows, patients with anorexia nervosa have leptin levels in this sub-physiological range, particularly if you compare them with age-matched controls. And even if you compare them with younger children, and then you can match for BMI, evidently still these leptin levels are very exceedingly low. So hypoleptinemia is a cardinal symptom in these patients. If you then during inpatient treatment, obviously the major goal is re-alimentation. So this girl came in with a BMI of 12.7, rather low BMI. Leptin levels basically not measurable at that time. And it takes quite a while for leptin levels to slowly but surely increase. Please note that that a level of 2 is still compatible with starvation. Range of 2 to 4, you're now slowly entering the physiological range, but it takes 70 days really to surpass this critical range. And then you can see with, again, further increasing BMIs, leptin levels go way up, and there seems to be a period which, despite maintenance of same BMI, leptin levels go up and down quite a bit. Actually, these two levels here are higher than you would expect for BMI matched people. And then in this case, this patient again lost weight, so obviously entailing another reduction in leptin levels. Early on, it was already clear that this, if you increase BMI, you obviously have a stronger effect on percent body fat mass. It goes up, and this increase in fat mass will then lead to your elevation of leptin levels, as I just showed. And if you look at, for instance, the gonadotropins FSH and LH, this is always the same pattern. The first one to pop up is FSH, and the second one to then follow is LH. And leptin obviously is the trigger of this increase in both of these gonadotropins. And this was the first attempt to address the psychological aspects or behavioral aspects of starvation in an animal model, thanks to Cornelia Exner, who performed this experiment with us in Marburg. And basically, it is related to the anorexia-based activity model for anorexia nervosa, the most famous animal model for this disorder. And as you can see, if you allow access to food, then food restrict, activity levels go up in controls. But if you apply leptin at the same time, then you can see that this elevation, this increased activity going up to about 300% is curtailed. So the first evidence that leptin has this significant effect on a behavior, in this case, hyperactivity. And we were also able to show that if hyperactivity has already set in, and then you start with leptin treatment, again, you can treat this you can basically treat hyperactivity, and it goes back to baseline values. And Stephanie, and this is how we got to know each other because I was really fascinated by your experiment using the STAT3 knockout mouse, which has a reduced body weight, reduced fat mass, and also enjoys running. Runs for 11 kilometers instead of 6 kilometers and has a decreased feed efficiency. And the conclusion of your experiment was that leptin influences motivational effects of running via leptin receptor STAT3 modulation of the dopamine tone, and that falling leptin is hypothesized to increase stamina and the rewarding effects of running as an adaptive means to enhance the pursuit and procurement of food, which again has clear-cut implications for patients with anorexia nervosa. Actually, you pointed this out in your article. Now, back in 2006, we had assessed activity levels using an ActiWatch in patients, and set the measured activity in relationship to leptin levels. And we found an inverted U shape, meaning that if patients are close to death, basically, activity levels likely go down. At least this was our interpretation of the data. And if they then gain weight and leptin levels go up, activity levels decrease again. For time, an interesting question is whether circulating leptin in outside of anorexia nervosa also predicts activity. We looked at lean Tanzanian children, and indeed found, without being able to go into the details for time reasons, we did see that these lean children who had the highest levels of physical activity also had the lowest leptin levels. So maybe there's also a physiological component and not just the hyperactivity in patients with anorexia nervosa. Then there are studies that have looked at patient groups, different patient groups. You can see here anorexia nervosa, but also hypothalamic amenorrhea or obesity or healthy controls. And the idea was to see whether or not there is a relationship between depression levels and serum leptin levels. And again, there's seemingly a very clear-cut relationship, at least according to this study, which focused on conditions associated with very low leptin levels. So this obviously leads to the question, can we use Metroliptin to treat patients with anorexia nervosa? And the company here is Amryt Pharmaceuticals. Interestingly, the Metroliptin was approved for treatment of patients with generalized lipodystrophy, which can be either a congenital or acquired during lifetime. Also, it can be used for, has been approved for use in congenital leptin deficiency. In Europe, it's generalized lipodystrophy and treatment-resistant partial lipodystrophy, for which this substance has been approved for. There's no clinical trial, so we thought that this might be helpful for hyperactivity. But we also thought maybe this would also help to reduce other starvation-related psychological symptoms. And we also hypothesized that maybe patients are in some way addicted to their starvation. If some of you treat patients, at least in the acute phase of the disorder, you have the impression that they are resistant. You can't really convince them to gain weight, and they seem to be trapped within their eating disorder and by themselves or without realimentation cannot recover. So we initiated case studies, and I'm grateful to Gabriela Milos, who treated the first two patients in Zurich. We didn't want to start off with adolescents, and we were keen on having patients who would be able to provide informed consent by themselves without their parents. By now, we have experience with 10 patients. The major problem being the high price of Metroliptin. It costs about 1,200 to even up to 1,800 euros per day. So it's exceeding one of the most expensive medications in the world. And this obviously tremendously hampers further progress within this field. These 10 patients, one male, treated in 4 hospitals, standard treatment. So this was on top of standard treatment. Many of these patients were so seriously ill that they required co-medications. We used dosing periods from 6 to 24 days. I'll show a single patient who was treated for a longer period of time. And dosages were basically similar to those used in patients with lipodystrophy. What did we find? Luckily, I must say very luckily, because if the effects would have been of a late onset type, we would have never been able to pinpoint them, because it would have been just way too expensive to treat patients for a longer period of time. And Gabriela, I remember her calling me just, I think, 2 or 3 days after the initiation of the treatment of the very first patient, stating that she experienced a tremendous boost in mood, an antidepressant effect. And then a few days later, the mood was so buoyant that she was kind of almost worried that this might turn into a manic episode. There was improvement of sleep, which is one of the very early symptoms, patients who have sleeping problems will state during first night after first treatment episode, or after 2 nights maybe, they will state that they have a qualitatively and quantitatively much improved sleep. There's a reduction in inner tension, reduced urge to move. I already mentioned the antidepressant effect. Interestingly, the social interaction seems to be improved beyond that you would expect due to the antidepressant effect. The preoccupation with food goes down. There's less fear of weight gain in patients, then questioning this distinction between primary and secondary symptoms in anorexia nervosa. There's increased appetite and hunger, at least in 3 to 4 of these patients, very clear indications that the suppression or the no longer existent appetite and hunger was turned off during Metroliptin treatment, basically already after, again, treatment for 2, 3 days, 4 days, and that they will then start reporting, oh, I experience an appetite again, and I even experience hunger. There were also somatic findings, for instance, less constipation. This is what we used visual analog scales without really knowing that we would really be able to pick up any effects, at least on a short-term basis. And as you can see here, this is the very first patient, a rapid deterioration in many of the symptoms that we asked these patients to rate in this case 3 times a day. Repetitive thoughts of food goes down, drive for activity goes down, feeling fat goes down, fear of weight gain, inner tension, depressed mood. Interestingly, the drive for activity was the one to respond less than the other phenotypes. This is the one where we had originally hypothesized that we would be able to see the strongest effect. This shows just to go through some of these very similar picture here, everything goes down. This was a patient who had originally been rather obese, 92 kilograms. During her anorexia nervosa, had the minimal weight was 33 kilograms. Upon initiation of this trial here, she weighed 42 kilograms, and everything here goes down, including, again, feeling fat, but also fear of weight gain. If you look at both self-rating and clinician-rated scales, this is an overview of a male patient who was treated for a longer period of time, up to day 24. You can see that the CDR-S score goes down substantially already after 5 days of treatment, goes down, doesn't really go that much down, further down after 15 days, but look at the self-rating, 58 in the beginning, and then already you're down to the normal range as of day 15, but also you have a very substantial reduction already at day 8. Similarly, if you look at the score for the eating disorder inventory 2, the raw score goes down substantially, even though if you look at percentile rank, this really doesn't have that much of an effect because of the very high original values of the raw score. If you look at HAM-D score in a few patients, again, you can immediately see that there's substantial reductions. I showed the BDI again, and this is a number of 4 patients. Again, this is the boy I just showed here. And again, the CDR-S pre-dosing, post-dosing. And please, again, realize that we're talking about effect setting in a very short period of time. Just to again go through the time aspect, so and to also illustrate that seemingly, and this is the observation that we obviously uncontrolled observations, no placebo controls. it seems that if the depression goes down, that even if you then discontinue treatment, depression levels do not go back to the original values prior to initiation of Metroliptin treatment. In one boy, we were able to see that there's an increase in testosterone already after 5, as you would expect, basically, due to the neuroendocrine adaptation hypothesis pointed out, or the data point that HEMA originally reported, setting in very rapidly. In clinical terms, this was also very significant because the boy all of a sudden came up to me and said, well, he just has a couple of phone numbers from female patients, and he was quite fascinated by the fact that he was all of a sudden interested in girls. This was a non-topic just a week prior to the treatment. Looking at the levels of leptin during serum levels of leptin, obviously we were measuring both endogenous leptin and metroliptin in these experiments. It goes way up and reaches very high levels that you would typically encounter in patients with obesity. So we cannot really at the moment say whether you just need to transverse the subphysiological range, enter the low normal range, or if this tremendous boost has a separate or an additional effect. So this is open and needs further study. If you look at parental comments, so stop permanent crying, laughed for the first time for more than 6 weeks. I think this was already day 1 or day 2. Became clear in his thoughts and expressions, smiled a lot, showed very good mood and made jokes. As time goes on, allowed huggings and kept smiling, all within a matter of 2 weeks. And at the end, his former personality is basically back or is reappearing. Just another patient here. She had to be fixated in our department because there was no other way of introducing food, and we were very concerned with her, but for ethical reasons, we then decided that we would discharge her and hope that she would maintain her very low body weight during at home, which she basically did. But due to her very poor condition, we offered this patient the Metroliptin therapy for 8 days. So again, very short time period. And the antidepressant effect was very noticeable at day 3. And in this patient too, appetite and hunger increased during treatment. And it basically, after this short treatment phase, I had 3 to 5 minute talks with her daily. And the idea was for her to introduce a novel food every day, which she was very well able to do. And she has now, we're talking about 3 months after the therapy, she is now at 60 kilograms. She does have problems with, or she did and still does have problems with binge eating. And there's a history of maternal obesity. Her mother writes tremendous progress. Mood is usually positive. She has lots of energy, can attend school without problems. She has extended breakfast. She can take her food to school. And here again, this patient already during, I think, day 3, 4, reported having an appetite again, was hungry. The food preoccupation also, the last time I talked to her she said still maybe 15 minutes, and compare that to 7 hours or more during at baseline. So again, a very positive remark. This is a 20-year-old patient. I'm running into time problems here. 4 treatment episodes, a very, very chronically ill patient who had been ill for 8 years, whose body height was stunted due to anorexia nervosa. In this case, we were able to treat longer because the health insurance paid for the Metroliptin treatment. And again, but to a much less extent than in these other patients, increased social interaction, increased openness, antidepressant effect, slightly improved urge to move. If you look at the BDI-2 score, you can see that again, this patient reported lower depression rates, even though they still are in the range of a depression here after they dropped substantially from the baseline values. Interesting is the weight. This patient gained weight under Metroliptin quite well. As you can see, it was very very dangerous and very low body weight initially, gained up to 29 kilograms. Unfortunately, the hospital was unable to be, she had already been in the ward for a year, and so she had to be discharged, and the date was disclosed to her, and this led to a profound crisis for the patient, and she then refused to continue treatment, so it had to be stopped here. But again, prior to the end of dosing, a renewed weight loss, which the team thinks is related to the disclosure of the discharge date. What we obviously need is a randomized controlled trial. I don't want to go into details, but we are thinking of 2 to 3 weeks of treatment and a post-observation phase of 4 weeks to then assess body weight, and after 3 weeks to assess, or 2 weeks to assess the antidepressant effect. I didn't tell much about somatic symptoms, which we anecdotally observed in some of these patients, including effects on hair, skin, constipation. So we have effects on mood, we have effects on social interaction, we have much less rigidity, compulsiveness, we have less weight phobia, we have obviously a substantial reduction in preoccupation with food, increase in appetite and hunger in some patients, we have reduced hyperactivity, and we have this effect on libido. And now we really do not know how these, whether or not these are separate effects, or if they're, for instance, related to the reduced preoccupation with food, if this then leads to a reduced mood. I don't think that this is the case, but it can be. We don't really have a good idea of also whether social interaction merely improves as a result of improved mood, or has a different, there's a direct mechanism. So there's lots of issues to clarify. We think that if patients start losing weight, leptin levels obviously will decrease. During COVID, we are seeing a lot more younger patients, many more patients than we used to, because they have more time. They want to enjoy or try to diet. They experience this positively, and as time goes on, and if weight continues to go down, leptin obviously goes down further, and then all of a sudden they are trapped within their eating disorder, and then you have all these problems that are associated with starvation. This is the very last slide. Going back to the Minnesota starvation study, I found this very interesting because of the implications for patients with anorexia nervosa and implications for the observed effects of Metroliptin are clear. These 32 probants during the realimentation phase were allotted to 4 groups with different caloric intakes, and this is basically the recovery of percent of deterioration in depression. So it's basically, if it goes up, it means improved mood, and the group that has almost totally recovered is the group that receives the most calories. The second group is the one that has the second most calories, and so on. And you can see that the group with the lowest amount of calories during this realimentation phase, actually that their mood initially goes up, probably because everybody was happy that the starvation period was over. but then really there's not much going on. And if you look at the weight gains of these probants, so the group that really hadn't improved at all had only gained 3 kilograms, versus the other group here, the highest one, with approximately 9 kilograms of weight gain. So I think this is very interesting to have really try and attempt to bring findings in starvation together with those observed in patients with anorexia nervosa, and then to think about metroliptin or leptin as being potentially a sort of a switch that turns on these starvation-related effects. These are my acknowledgements. Maybe Gabriela is in the audience. I'm not sure. I sent her the link today. And I had visited her 10 days after in treatment of at the end of the dosing period of the very first patient, to then also interview this patient. And it was a fascinating experience. This is her hospital. And maybe this will someday be an important turning point in the treatment of patients with anorexia nervosa. Obviously, lots of work to do. We can't exclude expectation effects for many reasons. I think they're not. Cannot be the explanation. Obviously, safety issues need to be addressed, and we need randomized controlled trials to continue the work. Thank you very much.
Thank you so much, Johannes. Really wonderful talk, exciting data. I find this such an elegant example of biology and a wonderful story of science, especially since that leptin was this once heralded anti-obesity hormone, could end up being this anti-anorexic treatment. So it's really lovely to see that, and it's lovely to see the work that you're doing and the promise, or I'll call the near promise. I know more has to be done, but it's very exciting in terms of treating this debilitating disorder. So please, everyone, if you have any questions, please post them in I believe it's in the question and answer box. I will start myself while other people could be writing. How far out have you gone? So I saw the longer term treatments. What is the longest time period post treatment that you've looked at?
The first patient who was treated by Gabriela, I think this was back in the middle of 2019. And as far as I know, Gabriela had recently contacted her. She's back at her job. She's doing well. So this is an observation period of maybe almost 2 years now, post-treatment. And for the other patients, there's this one boy, I think this would be a 1 year post-dosing period. Also totally recovered. The girl I just showed treated for 8 days. I wouldn't say, well, weight is back up. She's no longer anorexic, but she still has problems with as I said, with binge eating, and I think this will be a longer process. Mood is much improved. Back to school, so functioning, but still with problems. So it looks promising, but it's obviously you need randomized controlled trials to really understand this.
That's very promising. And so none of those patients had any intermediate doses. It was just the initial dosing, and then there was nothing, no treatments.
I have one patient that didn't show, who was had very serious psychopathological symptoms. We treated her first time around for 14 days, tremendous improvement again. And she, after that treatment, wrote a short essay basically explaining that she had always been locked up in a room, and that she perceived being locked up as the best thing she could do with her life. And that after these 14 days, she for the first time realized maybe I should attempt to open the door, or I should allow other people to come into the door and help me. And she did have troubles afterwards, and we went through another 1 week treatment period, and again, during that period, another improvement.
Great. So I have a couple of questions here. One from Thierry Alquier. Wonderful talk. Thank you. How difficult do you anticipate it will be to determine the optimal dose? Also, do you know if the treatment is affecting metabolism, for example, glycemia or insulinemia?
I would expect the treatment to have an effect on metabolism. We didn't really look. Well, we had one boy for whom the male patient, we found that actually the hypoglycemic, the number of hypoglycemic events actually decreased one day, were already decreased one day after treatment. So he had continuous glucose measuring. We are aware of an increase of blood cells during treatment in the first patients, but there's no systematic assessment of metabolism other than no. I showed you the effects on LH, FSH, and testosterone in this male, but no other findings at the moment.
And as for the dose, as Thierry is elaborating,
yeah, it's very difficult.
For maintenance of leptin sensitivity, how will?
Very difficult to tell, and there are many questions related to that. So maybe this just one single dose a day might be better to have just or split it up into 2 doses or even 3 dosages during the day to have a more constant level. The way we did it, the levels went way up and then dropped substantially due to the half-life of 3 to 4 hours of Metroliptin, and we're back, basically almost back to the endogenous level at the next morning. But no, we don't have. This has to be looked at. No clue.
Manon Duquesne says, thanks a lot for your talk. I was wondering if leptin treatment during anorexia has different effects between women and men. Do you have any assumptions about treatment sensitivity?
We were amazed that the male patient, aged 15, showed a really strong improvement in mood. But based on one patient, I cannot answer the question. It works in both. That was based on n equals 1. We can state it works in males too. Yeah. Same effects.
And Cecile Hirchuk asks, also given the excessive price of Metroliptin, would intermittent but for longer term low-dose Metroliptin be considered? And are the patients that you've been seeing, have they been following behavioral therapy after terminating the dosing?
It is, I think, to my point of view, it's crucial to embed this in a very clear-cut psychoeducational program or psychotherapy. So yes, they received lots of information, and they were obviously, at least for the last few patients, I tried to nail down aspects that they would like to work on if they experience a improvement. And some of these patients are so depressed and so entrapped in their eating disorder that you can't get anything out of them, but others are at least give you vague ideas of what they would like to tackle, and then use the momentum gained within this short time period to with their substantially increased motivation, they are then, and their reduced depression and their reduced other psychopathological features, they are then able to really tackle these issues this is the impression I have. So it's a short-term treatment. I don't think you need a long-term treatment, because obviously they need to gain weight, they need to get their own leptin production going, and this takes time, and they basically have to do this. They have to eat, and I think this short-term treatment is enough to sort of lift them, open the cage, let's say, so they can walk out of the cage if they want to, and then slowly but surely make progress and gain back their functional ability.
The Metroliptin is something like a big, sort of like a jump starting the entire process and opening many doors for better reception, I guess, of all these things. Yeah. Yes,
that's the way I interpret this. Obviously, there was one patient that I showed who I showed that was treated for a longer period of time, and so we don't know, for instance, if this antidepressant effect holds up for how long does it hold up. We really can't answer these questions. So it's basically only most of the patients, almost all except this one patient, all treated for 6 to maximum 24 days.
I will take one final question again from Thierry Adke, who's asking about patients with congenital lipodystrophy. And is it known that metroliptin treatment in those individuals improves mood?
These are data we're analyzing currently. I contacted Michael Stumpfel in Leipzig, who oversees treatment of patients with congenital lipodystrophy. And yes, there is they hadn't really analyzed the data because, and they had also thought that maybe the reduced, the strong reduction in depression based on, these are 10 patients, if I remember correctly, after 1 week of treatment, so very similar picture, that they had thought that this was due to their alleviated hunger, and that this had caused the antidepressant effect, and they didn't, as in internal medicine department or specialists, they didn't think that this is that worthwhile to report. So we now have the data, and we're working together with them to get this publication set up.
Fantastic. Well, Johannes, thank you again for joining us. It's now past 7 p.m. your time, so I think we'll let you go. Thank you, and look forward to seeing the continuation of this work. And yeah, I hope RCT can be done in the near future.
Thank you very much. Enjoyed it. Bye-bye.
Bye, everyone.